Thanks, Elena. Before we open it up to questions, I want to express my deep appreciation for your willingness to use the word messy. And I want to challenge all of you to understand that if we can't figure out how to fix some of the messes that Elena was just describing, and she's about as far along as anyone is, which is why we asked her to be here today, then we're back where we started, folks, which is we are spending a lot of taxpayer dollars, ruining a lot of lives, and not having a very efficient system. So the challenge before us is how do we clean up that mess? And with that, my staff are out there with microphones. If you'll raise your hand, someone will come to you with a microphone to ask a question of any of our panelists. If you could identify yourself, please, before you ask your question.
I'm Ken Feingold from the Office of the Assistant Secretary for Planning and Evaluation in HHS. And I want to thank the panel for talking about this intersection, which within the federal government involves us with the Department of Justice. I wanted to ask the help of everybody in this room in getting a message out because today is April 3rd rather than March 31st. As you may have known, we spent a lot of time in the last few weeks telling people to sign up before March 31st because open enrollment is ending, and you probably heard the presidents say how on Tuesday that we ended up with 7.1 million people selecting plans in the marketplace. Now we have to tell everybody it's not too late because that deadline was real for a lot of people, but it only applied to the marketplace. It doesn't apply to Medicaid, it doesn't apply to CHIP. There are many people who have qualified for special enrollment periods for circumstances like getting out of jail or losing a job or getting divorced or having a child. There are some people like enrolled American Indians and Alaska Natives who are not subject to that restriction at all. And now that having worked very hard to tell people that Monday was coming, we now have to work equally hard to tell people that many of you are still eligible. And that includes everybody in the Medicaid age range, which from what we've seen is most of the people that we're talking about today. So I just like your help in getting the message out.
Thanks, Ken. I got one up front.
Hi, I'm Erin Henderson-Moore, and I'm from the Department of Healthcare Finance. That's the state Medicaid agency in DC. And we're really working on a suspension policy for incarcerated individuals in our local jails. We're experiencing so many things, messy every step of the way. Every time we are ready to implement, we're pushed a month back. So we're shooting for June, but we've been reaching out to states, reaching out to CMS for guidance, how states are working, trying to work this out. And we're not getting a lot back from CMS or really other states, but one of the issues that we're finding is the household composition issue. So if somebody goes into jail, they're a member of a household, at what point do we redetermine? So they probably went into jail under we're a Medicaid expansion state. Let me just give you a Medicaid expansion state. We expanded to childless adults in 2010. So we've been covering this population for years. But we do have, many of our jail population are also members of families, have children while in jail. So at what point do we remove someone from a household in terms of eligibility? At what point if they go into the hospital? You know, and haven't received any guidance. Are you facing that in Rhode Island? How are you handling that?
I don't have to do
any guidance that?
Okay. Yeah, no, I don't know. I have no idea. That sounds really bad. No.
Messy is the word. The word one uses messy, Elena.
I have a feeling we're dealing with it. Let me get back to you, though.
It's actually a fascinating, we're going to ask Rich Lucia later, the sheriff from Alameda County, to talk about some of the work that he's been doing. And this big challenge is the definition of family size. If you think about it, we contain, and we'll be talking about this more later, we contain within our jail booking data almost everything we need to enroll a justice-involved individual, except for one data piece, family size. And so the challenge is, how do we define family size? And because most of these folks are not in the data hub, because they have not exactly had legal income that they've been paying Social Security taxes on. The question becomes, the verification challenge on family size becomes even greater. So frankly, I think, Elena, and to some extent you in the district, my answer is going to be the U.S. states are going to have to bear some risk. And you are going to have to bear some judgment risk on how you call it, because as we define the system, as we define the error rate, we didn't take into account that we would have, I think, Marsha, your number is 35% of new Medicaid, potentially new Medicaid enrollees will be jail involved. Is that your number?
No, 1 out of 6.
One out of, so, no, nationally I'm saying.
1 out of 6 of new Medicaid enrollees, but about 30% of jail involved.
Okay, yeah. So what I'm saying is that we didn't take into account that I would have such a large sector of individuals who would not appear in the data hub. That at the point at which the data hub design was created, there was these folks were as hidden from that as they are hidden in our day-to-day lives, okay? And so I think that is the significant challenge we have to figure out. And you know, you guys are on the hook. So Elena, you're on the hook. You're on the hook on the program integrity piece. You guys are on the hook. And so at the end of the day, you're going to have to make a policy judgment and try to convince CMS at a later date that you made a reasonable assumption with folks who were not part of the data hub, and they're not going to be there. More questions?
Steve,
yeah.
you just mentioned that we have tried to engage with CMS, and they are supportive and open and favorably inclined and all of the above, but the precision of the guidance is not there yet. So I mean, I think the notion of that you're just all out on your own and you just have to take a chance, at least you're taking a chance with a friend right now. I mean,
I agree with that way. I think we're all friends in this room. Dan, whoever has the microphone, I got a lot of questions filtering around here.
Hi, I'm Mark Levin with SAE and Associates and also with the Sentencing Project. My question is about private prisons, and is anyone reaching out, and what are the barriers you're finding there, since they're not within state systems and so they're not natural allies?
So I'll try to answer that. There's no legal distinction between a private prison and a public prison in terms of someone being an inmate of a public institution. I think the challenge is, and you will hear me later in my closing remarks talk about, that it may be that the private sector leaps ahead of the public sector in addressing this population, and I'm going to defer that till my closing remarks. More hands up front, whoever's working the mic. Yeah.
Penny Mills with the American Society of Addiction Medicine. I was very intrigued to hear the innovative work that's going on in Rhode Island and the way you're looking at data to understand the medical and addiction and other conditions of the inmates. I was curious, though, when you were talking about the challenges around residential care, there are clearly other levels of care that could be options for those individuals, and I was curious about how you're looking at those other levels of care besides residential.
Sure. So I did mention residential care because it is uniquely impacted by the IMD exclusion. Again, we're fortunate in Rhode Island where I think, and I'll look to some of my Rhode Island colleagues in the audience, I think in general we have a relatively robust substance abuse prevention system. But in terms of the different services and treatments that are available. But again, it's been sort of forced to be limited to somewhat sporadic funding because it's either grant-based or general revenue completely, SAMHSA grants. And it's not been available to large groups of people. So what we are trying to understand, and folks have talked about the substance abuse and mental health portions of the essential health benefits. So what we're finding is the benchmark plan on which those essential health benefits were based really does not come close to what we see people with pretty intensive needs need. And I don't think we're going to get there through EHB. We really, this is, I think, a publicly financed issue that we need to deal with on that end. It's really not, I may be wrong, but it's not really going to go into the commercial world. So we're trying to understand the services, the evidence-based practices, what is really the most recommended treatments, and trying to fund that but the worlds of the managed care organizations and some of the providers are very different, and they haven't had a need to work together in the past. So that's what we're dealing with.
And I want to add two things to that from the COCHS end. One is we like mentioning the TRICARE model for those of you that are not familiar with it, which is a partial hospitalization model that is packaged with a sober housing unit. The partial hospitalization become a Medicaid benefit. The sober housing may, under some circumstances, be a 1915I eligible benefit in certain states. The other thing we've been working with certain states to think about is this whole issue on the IMD exclusion and how IMDs are defined. An IMD is defined as a facility whose primary function is the treatment of a behavioral health disorder for more than 50% of the individuals treated that is greater than 16 beds. The query we've been raising is if the primary function of a residential facility is to address a criminogenic behavior pattern, does that fall under the IMD exclusion or not? And we have yet to get, although we have friends at CMS, as Dr. Summers has stated, I think that's an outstanding issue that's out there as well. More questions? Oh, I've got a lot.
Hi, my name's Elena Tievsky. I'm with the National Council for Behavioral Health. I completely agree with the need for federal funding. I think the Excellence in Mental Health Act will be great in solidifying some federal funding for behavioral health centers. We're working on a project, a learning community, linking community behavioral health centers and departments of correction, and trying to streamline enrollment processes, eligibility determinations, and linking community behavioral health centers to criminal justice systems in the hopes that we can streamline the process of linking these individuals to services. Obviously, the struggle is health information technology systems that support this, data sharing, and the cost. And I think also the sustainability. So our fear is that while we will help them implement systems, when we leave, will they see the benefit to sustain these systems? So I'm interested just in any information you have on your project and really making the argument that it's worth it for them to continue this, for them to invest in this, and the sustainability piece that it's actually working out.
Convincing the correctional side to invest. So I feel like we should be much more successful given the underlying structure, but our corrections has invested in an electronic health record, and we're at the point where we're working with them to see about transferring data from them to the managed care organizations. They're very open to that. So to some extent, the investment has already been made. Where we are looking for opportunities is we have a health information exchange, a statewide health information exchange, and I don't think that people had thought about the corrections department as a source of people to enroll in that health information exchange. So we're pursuing that pretty actively.
And in fact, that will be our last panel of the day, which Linda Rosenberg, the head of the National Council, will be on. You mentioned something. I was going to wait until Linda came on, but I want to congratulate on behalf of COCHS, the National Council. For those of you that do not know what you were just referring to, in the SGR revisions that happened on Monday, the Excellence in Mental Health Act was incorporated as part of the SGR fix. So I'm sure we'll be hearing more about that from Linda later. I think there were questions on this side. Yeah.
Hi, I'm Judy Solomon, Center on Budget and Policy Priorities, and it's really, really excited to be here and talk about the implementation. And messy is a word, Elena, that I think I use many times a day. But if I could, I'd love to just step back for a minute and think about the almost half states that haven't expanded Medicaid, where these opportunities don't exist. One of the concerns that I think we have is that some of these numbers are actually being used in a way to undermine the expansion in terms of, you know, some really ugly rhetoric about covering people who are jail involved, and we're trying to sort of counter that and pivot to the importance and success and the benefit, you know, fiscal benefit to states, obviously benefit to people. So I would just love anyone, Steve, you or others, to really sort of think about how the positive stories you have can be told to help move, you know, some very, very big and important states for the groups we're talking about that haven't expanded yet and don't have this opportunity. So, and then the other thing, I'm just going to make a plug on the household and all that stuff for a website that we have where we have a lot of the information on those really nitty-gritty rules. It's called healthreformbeyondthebasics.org. So hopefully you can find some of what you're looking for on those household rules, and look forward to the rest of the day. So thanks.
Steve, you want to cover non-expansion states?
Well, we know that there are a number of non-expansion states, and that it's slowly, that number is getting smaller, and we'd like to see that number continue to get smaller going forward in order to create the coverage opportunities we've been talking about. And we know that there are arguments and counter-arguments, and Steve, you've been very involved in at least bringing them to the attention of folks about the value to the state of enrolling people, including these folks, in Medicaid coverage. So, you know, there's some people who've been watching Medicaid for many, many years who say, well, it took Arizona 20 years or 15 or 17 years to enact Medicaid in the first place. You can't expect the expansion to happen immediately everywhere, and there are those who are willing to take, those in high places who are willing to take bets that all states will expand, except maybe one or two, within, you know, a period of time, a reasonable period of time. This is something that's going to roll out more slowly than what we might wish, but it's going to happen in many places.
And Judy, I would just add something, as that, you know, from the COCHS perspective, it was really Governor Perry of Texas and Governor Deal in Georgia who were the leaders in taking us to understand this relationship between treating underlying behavioral health disorders and the criminal justice system. And they did that on their own with state money. So I think the question becomes, to what extent do jurisdictions choose to continue to use their own state money, or to what extent do they want to use federal money? I think, frankly, from the COCHS perspective, the crucial question is, how do we develop systems that treat the underlying behavioral health disorder to save the tax dollar so I don't have such a dysfunctional system that we have right now? And I think when you look at the kind of experimentation in Arkansas, in Iowa that's going on, one of the wonders of the Affordable Care Act, Dr. Burroughs-Byron will be talking later about some of the efforts in Vermont, is the panoply of opportunities that the ACA allows for states to determine that it's not one size that fits all. The criminal justice system, folks, are expensive, hidden, and sooner or later someone's going to pay the price. And so the question is simply, what's the best way to do that? I think there was a question here.
Yes, I just want to say briefly.
Could you announce yourself, please?
Yeah, my name is Barbara Dennis, and I'm here on behalf of Mothers of Those in Crisis. It's an, excuse me, it's an organization I put together about 34 years ago. I'm going to make this real brief because I'm really in awe. I just couldn't believe it when I got this information that this was even happening. But it started out with my son. He was 16 years old, and I saw him taking pills out of medicine cabinet. To make a long story short, he's now 54 years old. He's been in and out of New York State, Attica, back and forth. He's never had a victim crime, never hurt anybody. He's been on substance abuses, drugs, and by him going, I'm not going to talk long. I'm just here, and on behalf, and if there's any other groups here, I've been doing this. I have about 12 of us. We've been doing it volunteering. I've worked in prisons. I've worked in the I've got personal and professional experience. I've got so much experience that I can share with anybody. And if there's anybody else in here from New York State or concerned, I know that I can be an asset to whoever. And yes, I do have a passion for it. And I know that I'll be doing it for life. I'm approaching my 72nd birthday. I say that not to say, ooh, you don't, because that doesn't mean anything to me, because I'm feeling it. I've been suffering. I've got other children, but they've stood by me, and we're all doing fine, but we can make some changes. Thank you for bearing with me.
Well, thank you, ma'am. And I don't want to estimate the importance of parents and families. Pete Early's book, for example, about his son's travels between the mental health and criminal justice system, help focus on this. So we depend upon the loved ones who are out there in the community to help highlight this hidden population. So we thank you. Yes, sir.
David Gast, friend from the American Society of Addiction Medicine and Treatment and Research Institute in Philadelphia. What are the metrics for determining if the ACA interventions are working, and who's charged with or is going to take on the charge of developing the scorecard for where it's working and pointing us to those models?
Marsha, that's you.
I think Marsha at the university just got the answer to that one.
The ACA is not without dozens and dozens and dozens of ways to measure what's happening in terms of how hospitals are working, how accountable care organizations are providing an integrated range of care. There's lots of rules and regulations that will ultimately move the healthcare system to more of paying for value than paying for services. But I think I hear something underneath your question, which is how can we really tell how the most vulnerable people in our country are faring?
Well, specifically with criminal justice.
Right. So I am not aware of any. So the criminal justice system doesn't measure quality at all in terms of health care, and health care doesn't track whether anyone has an experience with criminal justice. So current efforts to measure quality under health reform do not specifically identify this population. And for reasons that I was sort of mentioning at the end of my talk, which is we don't know very much now, we're not set to know much more in the future. So targeted efforts need to, in some way, identify groups of people who have been involved with the criminal justice system. It's not just in jail, it's probation as well. You know, so it's the whole broad group of individuals, but we measure people by certain demographic characteristics, by income, by access to where they get care, for example, FQHCs or certain other hospitals. But I don't know in any ways that there's any current efforts or plans to measure quality for this population.
And I don't either, and I think that it's, I wouldn't even need quality. I mean, it's going back to Steve's point. I'd like to know about coverage, percentage covered, and then percentage getting access to services and the utilization of services. If that could be tracked for a subset of this population, that could be very valuable in the argument back that Steve wants to make to states that haven't expanded or to others, that this is worth the investment. And so that does take somebody standing up. And I don't know, Aspie volunteered to ask a question at one point. Maybe Aspie wants to respond, but it takes somebody stepping forward and saying, this is a subset of the population that we ought to study.
And I want to just answer that question in an oblique way. I have 3,300 county and city jails in the United States of America. There is no organized database whatsoever. I think that you mentioned, Marsha, and Todd's in the room, that most of the data that we derive from this depends upon self-reported data that the Bureau of Justice Statistics collects on an episodic and periodic basis that is self-reported, whose accuracy is in of itself open to question. That because we have been content as a society for the 11.6 million folks that travel in and out of jail every year to remain hidden, we have been content for any data in reference to that population to also stay hidden. So I would argue, and I think we will hear Homer Venters say this later this afternoon, that it is the opportunity of electronic medical records and transparency that, if anything, will enable us to gauge this over time. But I do not want to in any way de-emphasize the challenge of a pluralistic society with 3,300 jails and prisons without any way to identify who is in jail and prison to provide the kind of data that, as a researcher, I suspect you would best like. And I have time to give you a follow-up, and I have time for two more.
You can't fix what you can't measure.
I agree.
And you can't measure
what you can't fix.
What you don't know what you want to know.
Right.
So I suppose a COCHS and healthcare's working to establish measures and the basis for a scorecard, which then provides the methodology for asking the questions of the electronic health record and the criminal justice.
I appreciate that, and I'm going to ask you to revisit that in the Q&A at the last session on electronic records. Okay, I have time for 2 more questions.
Hi, my name is Will Eberly. I'm the executive director of an organization in Vermont called Another Way. We're a community center which caters to folks with pronounced mental health issues, addiction, trauma, criminal background, all that type of stuff. And I'm here for really 2 reasons. One, to let folks know that we have developed a way of working with people that's been very effective with the segment of society that people tend to throw away. Specifically, we're dealing with people who have been through institutions, jails, psych hospitals, all these type of things that are still actively homeless, that aren't getting help, that are living outside in a Vermont climate, 20 below zero in the winter, that type of situation. And we have a center that's open every day of the year. We work with 100 unique individuals per year with the same budget that the state spends on 1 individual per year in a psych hospital. And so I need to tell you today that we're on the brink of losing half of our funding through a federal SAMHSA grant, which, if that happens, we lose half of our staff, half of our ability to do everything. And so I'm here for the dual purpose of saying that, we've been developing ways of working with, the most difficult people to work with that are very helpful, that I'd be happy to share, consult, et cetera, with other organizations, and we're in the position of needing to diversify our funding. And so the reason this is so pertinent to me is that what I see in Vermont and other places is that when people enter the criminal justice system, they then lose most of the resources that they have in our state. They lose their health insurance, counseling opportunities, all of this type of stuff. And so what we're finding in our center is that when people have an opportunity to work with our counselors and folks who have their own lived experience with mental health issues, with addictions issues, homelessness, trauma, all of these things, which every one of our employees has, then they feel heard and valued and cared about in a way that then makes them realize that they have this human potential to be able to do anything. And so I just want us to, question a few of our underlying assumptions and stigmas, that people with pronounced, mental illness can't get better, that people who are in jail are there because they're bad, and that people that don't have jobs don't want to work. And so those are things that I see disproven every single day, and I'm here to try to help network with other people and get funding diversified and all that type of stuff. So just thanks a lot for the opportunity.
Thanks, Will. And before we do the last question, you reminded me of a data bit. Ben Butler, where's Ben? Ben Butler, our CIO from our staff, did a visit to the Pima County Jail, I guess it was last month, and he came home with a fascinating data bit. They had a 42% show rate at court for their seriously mentally ill population. And so what we had is this cycle that Seema was talking about over and over again, and the more someone fails to appear, the more high risk they are later on. So they instituted a peer support network at the Pima County Jail in 1 year. They had 100%. They went from a 42% failure to appear to a 0% failure to appear by the use of peer counselors. Oh, excuse me, it was generally 90. 1 year is 100%. So yes, Will, it's appreciated. I have time for one more question, and then I have to take a break.
I'm John Robinson. I'm medical director for Aetna Medicaid Managed Care, and just want to bring a little bit more focus on one particular mess in trying to solve this issue of suspending versus terminating eligibility. It's not exactly the same to solve that problem as it is to solve the coverage problem. You've already alluded to this. But getting the coverage is one thing. Getting a particular managed care organization to provide the benefits coverage is a different thing. And that gap between the eligibility versus the selection of a managed care organization is one challenge that I think I would plead with policymakers and advocates to try and address as they begin to solve this problem. It's going to be even more important. The initial phases is, of course, expanding the people who are eligible for these kind of coverage, but after that has gotten legs and people then continue to cycle through the justice system, that continuity of coverage is going to be an even bigger issue.
So, John, I'm going to ask you to defer that to our panel after lunch, which is exactly on that issue. And with that, we're going to take a break. If those of you have not figured out, I'm a punctuality freak, so we'll be starting promptly at 11 o'clock.